presenting with responsive behaviors, which we'll dive into today. Introduction, Julie did a great job. That's that. This is my cute dog, Millie. So yeah, I've been working as an occupational therapist for 2 years, and prior to that, a recreation therapist, all specifically on specialized dementia unit. So the specialized dementia unit I work on right now is housed in Toronto Rehab. We have a 17-bed program with more moderate to advanced stages of dementia, specifically with behavioral expressions. So we will get right into it. So I'm looking at probably 20, 25 minutes. I'll be presenting some things. I'm more than happy if you want to chat. Julie will let me know, and I can, if in that moment we can chat more about that, or I can answer any questions, I could do that. But I'm leaving room at the very end so we can have a discussion. If you have questions, if there's a story, if there's something, just, we can have a roundtable discussion about that. So what's really important to start with are the brain changes. This helps us understand exactly why someone may be presenting the way they are with their certain behaviors. So I want you to see on the left side, here's more of a normal brain, okay? And on the right side is someone with more advanced stages, later stages of dementia. So as we know, dementia, it's changes in the brain, it's chronic and progressive. What I really want you to see with this is, although, you see a lot of what we'd say atrophy, so there's a lot of the shrinking parts of the brain, there are still preserved abilities, right? So just because someone may have many brain changes, there are still preserved abilities and strengths and capabilities of someone that we really want to highlight. And it's different for everyone. Like the saying is, if you know one person with dementia, you know one person with dementia. It really is a very unique disease for the person and their stage. So we'll start the frontal lobe. So this is the part of the brain that controls most of your personality and behavior. So we often see people with frontal lobe dementia. This is specifically, you might see more personality changes. So more swearing or foul language. Some people may have experienced that if they were stealing, there might be an increased interest in sex, deterioration in personal hygiene needs. More socially inappropriate, maybe you might be seeing someone who's a bit more impulsive. If your loved one is presenting, sorry, I'm just going to mute that. And the joys of being in the office here. And this, you might also see emotional withdrawal or a lack of empathy, like the person just isn't really responding to social situations or maybe emotional situations as they normally would. So the temporal lobe, this is all about language. So this is producing and understanding speech. So if someone is talking to you, that person with dementia may not be able to process what is being said or understand the language. Language is really a big part of the brain and requires a lot of cognition. Okay, so we're just gonna let that ring through for a second. So your parietal lobe, this is where you receive and process information from body to skin. So this is the ability to perceive sensory input. So this is pressure or touch. So let's say if someone may have pinched their finger in a door, there is a signal that goes to your brain, then you process an output that actually says, okay, I'm in pain. Dementia may not have that intact. So then you might experience, that person may experience delayed, they may be in pain, but they're not able to express it, or they may not feel that pain because of brain interruption. The occipital lobe, so this is at the very back of the brain. So this is really difficulty working out what's in front of that person. So this often we see contributes to visual hallucinations. So people may misinterpret shadows for people, or they may just have a change in vision that they're seeing someone there. This also is your color perception. So often, like let's say, for example, in a bathroom, if there's a toilet, white toilet with a white wall, Often it is hard for a person with dementia to find the toilet because it's all blurred together. They just see there's no color contrast, and this may be part of the brain that's impacted. And also your ability to read. This is part of the brain that interrupts that. The last part is your cerebellum. This is the very bottom part close to your spinal cord. This coordinates your movement, your posture, your balance. So this is often what we see in the later stages of Alzheimer's and dementia. So this is really difficulty walking. People may be losing their balance and increased falls. Okay, so those are the brain changes. There's a lot more to it, but that was kind of the main parts I really wanted to show and help us understand why that person may be acting the way they are. Can anyone, you can even in the chat box, does anyone know what responsive behaviors are? Can you even put a word or anything? And if you don't know, that's fine too. But if you have any thoughts on what you think responsive behaviors are, you could put it in the chat and I'll see what everyone's thinking. And again, it's completely okay if you don't, because that's why we're all here. Don't know. Perfect. Good. Answering the question. Good. Okay. So you know what? Let's get into it. Let's start from the very beginning. What are they? So the term is basically, it is a term preferred for persons with dementia. So it's how their actions, words, or gestures are a response to something in their environment. This could be their personal environment, their social, or physical. The main thing, a lot of people may say challenging or aggressive. We try to stay away from those words, and that's why we say responsive. They are responding to something in their environment, and that's why they are experiencing some sort of behavior. So you might hear other words. A lot of physicians use the word behavioral and psychological symptoms of dementia, BPSD. So a lot of our geriatric psychiatrists or physicians would often use that word. You may often hear personal expressions or behavioral expressions, but mostly responsive behavior is one of the main words. It's a way to communicate. It is not intentional. The person with dementia is not doing these behaviors on purpose. It is truly just a way they are trying to communicate. So behavior is a response. So often when you have dementia, there's so many things that are taken away from you that this might be the person's ability to regain that control, send a message, or protect themselves. It also could just be a way to alleviate boredom, seek stimulation or companionship. Because of the changes in the brain, they may not be able to say, hey, I'm feeling really lonely. I'd like to hold your hand or sit with someone. They just know that they feel something, they can't express it, so it comes out differently. So what are some examples? These are the main ones I have seen. Vocalizing. So there might be constant requests for attention, or constant moaning, or a sound that is just all day constant, or yelling and screaming. So this would be your vocalizing. That's one part of the behaviors. Verbally responsive, so often foul language or threatening. I see this mostly with personal care. So toileting, showering, bathing, I know is a really common issue that we see this responsiveness. Restless, so this person, your loved one may be pacing, wandering, I like to call it exploring. It's not really purposeful. They just might know that there's something that's feeling off, so they're walking. It might be self-soothing, or they might need something, or fidgeting with something. We see a lot of people who are just moving things, tearing things. So that's what we would call restless. Physically responsive, this is hitting, throwing, hurting oneself, kicking, or biting. And this is often as a response to protect themselves in a moment. And again, quite common with personal care. But again, it's just sometimes a defense mechanism as well. So what we often would call disinhibited behaviors. So this could be sexual disinhibition. So again, this could be misinterpretation. Let's say in care, if I'm helping someone in the shower, and may be misinterpreted as a cue. And so you might see someone who is more sexually disinhibited, and masturbation is often a common one too in public areas because they're not sure where the privacy is. And disrobing would be with clothing. So often we see people removing all their clothes, or the opposite, people putting on layers and layers of clothes. So this is just the part of the brain that's disinhibited. So what are some factors to these behaviors? So we know what they are, we know the brain change, but what are some possible factors? And I'm telling you, you are going to be a detective, because it really is. If you're thinking about, you arrive on the scene of a crime, you look around, it's often you're looking at the environment, you're looking at the person, you're talking to the family. So you're a detective for your loved one. You have to, 90% of the behavior is often just going to be helping communicate or helping with your approach and learning exactly what's going on around them. How can I help them? Because they depend on us, the caregivers and loved ones, for assistance. So I'm not going to get into the whole thing. Pieces, you can find this on pieces.ca as well. The reason why I'm introducing this, that we use this often within the hospital and long-term care homes. I'm going to use this as an acronym for everyone. I'm hoping that it'll help you understand, let's say in the moment your loved one is having some sort of behavior, you can think of pieces as an acronym that we're going to go through that might help you sort of investigate or be the detective to help find out what's going on. So again, what are the risks? So this is, we'll start with the P, which stands for physical. Disease. So in the physical part of it, if you see that your loved one, let's say they're confused already, but you see a sudden acute change, they're acting really different, more different than they were the day before, go to your doctor, because they may be experiencing something called a delirium. So this is a sudden acute change in someone, okay? Another thing is, other than dementia, you want to look at their other comorbidities, so other diagnoses they may have. So another one is urinary tract infection. This is really, really big in this population. So often they just seem much more confused. They're acting different as well. Maybe delirium is ruled out, but the doctor may have to check their urine, because we often see an increase in confusion and behaviors with people with bladder infection. Constipation is another big one. So if someone maybe hasn't had a bowel movement in 2 to 3 days and they're constipated, we often see an increase in that person's behavior. So look at the other diagnosis or diseases your loved one may have, and that may help you understand what's going on. Drugs. This is with medication. So my main advice for you is, often someone with dementia is put on many different medications, and even just when you're aging, you might have a blood pressure medication, something for anxiety, something for urinary retention. Talk to your pharmacist, because there are drug interactions, there are side effects that may cause agitation, sleep problems. It could even cause a change in mobility. So talk to your pharmacist about this, and educate yourself about what are these medications. Ask, are there any side effects, or are there any interactions? Discomfort. So this really is, that person may be in pain. So I would recommend looking at instead of, sometimes they may not be able to actually say, I'm in pain, this is what hurts. You really rely on the face. So you may see facial grimacing. So you might see a change in face. You may see, if someone's more rigid or stiff, that often is an indication of pain as well. They just can't express it. There might be a change in appetite, posture, and sleep. These are all things that could be indicating pain. So again, just use your detective skills to see if maybe there is something going on. We often, in their advanced stages of dementia, we've had people with fractures, but because of that brain interruption, they're not able to process the pain. They just know that something's feeling off. So that's, where we use that detective hat to look, okay, well, what's going on? So this is where you can really rely on your physician as well. Disability, there's a few main categories. The one disability category is sensory, so hallucinations. This is a change in function with your sensory impairment. So this often, the most common hallucinations for persons with dementia are seeing animals, little children, or picking at the air, or picking things off the ground. It's mostly visual, or they may hear things, and then often all forms in dementia, this happens a bit later, but also this is common with Lewy body dementia. The second sensory impairment is delusion. So this is a fixed false belief. So people have certain patterns or beliefs that may not be true. So an example is often if some people feel like their loved one is having an affair, that someone is stealing from them. So these are all delusions, so those fixed false beliefs. Communication. So all conditions that can cause communication deficit. So a loved one may also have a stroke that may be impaired with their communication. The main thing is they may not be able to express themselves and communicate what they're feeling, hence why sometimes there's the behaviors. And lastly is mobility. So you often see a change in their ability to walk and their balance. So that's the disability part of the physical. So we've done the P of pieces, we've done physical, now we're moving on to the I, which is intellectual. Okay, so the first thing is memory loss, so amnesia. So ability, they don't have the ability to form new memories. Memory loss, you often hear that the short-term memory is mostly impacted, so what they did that day, what they did yesterday, but then they can remember 30 years ago. This ebbs and flows, your memory loss. They may remember one day they wake up, remember who you are, what they did 10 minutes ago, and then it may change in an hour. So this, again, because of the brain, it's kind of firing off in different ways. It really depends on the day, but for the most part, someone with dementia does experience this memory loss. Difficulty with communication. So someone may have a diagnosis of what is called aphasia. So expressive aphasia is something that they are not able, a bunch of words just come out, but it doesn't make sense to you, right? So the person with dementia is just all these words, they think it makes sense, so then they're frustrated because you don't understand them. And then receptive aphasia is they do not understand what you're saying to them. So your loved one would have a diagnosis of aphasia if they did have this, but in general, difficulty with communication is an issue. Apathy, which is really just loss of motivation. So you may notice your loved one just has a lack of interest in things that they used to really enjoy. They're not as enthusiastic maybe, or it could just be a loss of motivation to start a conversation, to brush their teeth, to start a task. So this again is part of the disease. Difficulty processing sensory information is something we call agnosia. So this is really inability to recognize objects. So an example would be, let's say there's a toothbrush out and a comb, and you say brush your teeth. They may pick up the comb and try to brush their teeth because they don't recognize that a toothbrush is meant. What is a toothbrush? What is a comb? Objects just look like objects. This could also be with shapes or sounds or faces. Difficulty understanding what to do. So this is called apraxia. So it's the inability to carry a skilled movement. So we often just see if someone's about to get dressed and they see these clothes, they just don't know where to start. The person with dementia, it's difficult understanding, oh, I don't know what to do. And that's where they really rely on the caregiver to help initiate or step by step. Okay, first we put on the pants. Now we put on the shirt, right? So breaking down steps. And I don't know what I don't know. I forget what I forget. So a person with dementia may experience something called anosognosia. So this is when they just do not know what they don't know. So this often can fuel paranoia or distress. So a common one is, let's say someone's about to have a shower and you say, okay, Joe, it's time to shower. Well, I just showered. but really they showered 3 or 4 days ago. But they don't have a concept of that. They don't know that they need to shower. They don't know that they need help. So this, again, just causes frustration for them and for the loved ones. And perception, what we kind of talked about with the brain changes, the main thing here is things may look farther than they appear or closer than they appear. An example is when there's a black mat, let's say in front of an elevator, this was common, it looks like a big hole. So the brain is kind of playing tricks on that person, and things look like either holes or they're farther or they're closer. So there's just this altered perception of their environment. So now we're on the E of pieces. This is emotional, which is really, really important. So mood. Just because someone has dementia doesn't mean they can't also have anxiety or depression, right? So this could also be something. Adjustment. So this is, they may have lost a loved one. They may have recently retired. They're moving. There's a lot of role changes as someone ages. So just because someone has dementia doesn't mean they can't feel that things are changing. There's an adjustment process. Trauma. So this could be a traumatic event. It doesn't matter what kind of event, if it's traumatic to the person, right? So right now, I have had a lot of recent admissions with people who have war-related trauma. So we do care differently. Their environment is different because we understand that that person has experienced trauma. So we have to be a bit more sensitive. Capabilities. This just means that if some people feel, this is often care, so their capabilities are overwhelmed and strengths are underused. If they're able to wash themselves, we want to encourage that. Instead of going in, sometimes the caregiver will go in and just start washing that person, and the person pushes them, because we're not understanding that maybe we're underusing their strengths. Maybe let's encourage them. Let's try to encourage them to wash themselves. And then the E of the pieces is environment. The most ones I see is they're overstimulated. There's noise, the TV's on loud, the phone's ringing, someone's talking. This is overstimulation, or it might be too bright, or they could be understimulated. It's really quiet, nothing's going on. They haven't done anything all day. And then we're at the last one, is social. So really, this is their life story. So what do you know about the person? You all know your loved ones the most, but does everyone, if you have caregivers coming in to help, do they know about the person? Cultural, there's different values, beliefs, traditions, and language. So is this properly incorporated into their day-to-day? Again, if caregivers are coming in, are they able to understand the different cultural traditions or beliefs that someone may have? Spirituality means many different things to many different people. So again, it's just an important thing to make sure it's incorporated in part of their day-to-day. In sexuality, there's often a lot of myths that a person with dementia is asexual. They're no longer interested in anything sexual. So really, it's just sexuality means different things. Maybe for a person with dementia, it may mean they just want intimacy. They just want to hold your hand, kiss, touch. It means different things. So that's still a need for someone. And lastly is gender identity. So if there are some people who identify as part of the LGBTQ community, we just want to make sure that we are mindful and that they have the support they need to identify and be themselves. Okay, so I'm going to end with strategy. So we know all this stuff, okay? We know all these changes. We have this idea of the possible factors when we look at pieces. Okay, but what do I do? So I could go on for 6 hours about strategies, but I wanted to just pick the ones that I find most effective for day-to-day that might be helpful for you. So know the person. So you know your person best, but again, if someone's coming from an agency, someone from home and community care coming in, just make sure you have maybe a list of information. What do they prefer to be called? What kind of job did they have? Who's important in their life? What kind of lifestyle have they lived? Did they love to travel? Did they like to talk about travel? What kind of interests or routines do they have? And what are their likes and dislikes? They might hate James Taylor music, but love something else. So these are all little details. If you know about the person, it's nice to express that with others. Go with the flow. Live with wherever they are. So, you know, yesterday I was just on a trip. I was out in the farm with one of my patients because they said, oh, I got to go do this. And they were focused. Okay, well, I'm going with them. I'm not going to say, no, actually, you're in a hospital. You're going to just go with the flow. And, you know, it's sometimes hard, but once you just let go and go where they are, it's often effective and it calms them down. Something called stop and go. Okay, so this is usually, let's say someone is really, you know, they're starting to swear, you notice they're starting to get more agitated. If you're starting to notice and you feel the need that, okay, I think this person is, my loved one is getting a bit more agitated, first you're going to just stop what you're doing, or anything can wait, okay? And then you're going to think about what is happening. So use your detective skills, look around. Is the environment too loud? Is it, you know, is someone talking too much? What might be causing this increase in agitation? Then you're going to just observe, and then you're going to plan. Should I, you know, do I need, if you're starting to help someone, you know, go to the toilet or have a shower, do I need to do this right now? Can I reapproach? And then go, right? So stop what you're doing, assess the situation, and then go ahead, whether you can continue, you feel safe to, or if you need to reapproach that person and let them have their space. This is the first thing I do with people. I call it the unmet needs checklist. This is the first thing I do. I check, okay, are they hungry or thirsty? So I'll say, okay, Joe, are you hungry? Yes. Or are you thirsty? And again, just using one word questions. You go through there, okay, they're not, or if they can't communicate, just try giving them a cracker or cheese or something to drink. Are they tired, right? Some people just pace and pace and pace, and they're probably tired. So you might just want to try bringing them to their bed, cueing them and say, okay, sit down, lie down, and they may just fall right asleep because they're overtired, but they didn't know how to stop. Or are they revved up? Are they just super, super, super high energy and they need to maybe walk more or do something? Toilet. This is probably the most common thing. When someone has to have a bowel movement or they have to pee, but they can't find the toilet. So I always say, okay, do you have to pee or do you need to use it? I try to use as few words as I can, or I take them right to a toilet and then often they need to go. Or if they're wearing a brief or if they're underwear, if they're soiled and they're uncomfortable, to change. And are they in discomfort or pain, right? So going back, are they facial grimacing? Are they rigid? Is there something, often in their feet, look at their toenails, right? Or are they, you know, is a toenail caught somewhere? So just, again, use your detective skills, look all over and see if something can be bothering someone. Communication, short, simple sentences. I try to even say 1 to 2 step instructions. Take down your pants, pull up your pants, 1 step at a time. So there, 1 to 2 step instructions. Be aware of your body language and tone. They will mimic exactly how you are. If you're tense and anxious, they're going to feel that energy. So just be aware that you have this open body language, your tone is calm and soft. And make sure they can hear or see you. Do they have their glasses on? Do they have their hearing aids on? Are you standing right in front of them where they can see you and you're speaking? And respond to the emotional theme or idea. So if they're sad, if they're looking home and they're sad, respond to the sadness. So we're going to use an example here. So GPA stands for gentle persuasive approach. All this means is, let's say right now, someone really, really wants to go home. Okay, so first you're going to do is you're going to put your hand out. I always put my hand out when I see someone, so it gives them time to process I'm coming towards them. They often take my hand and shake it, and then I often just turn my body to the side so I'm not overwhelming them. And you can distract with something, but in that moment I just say, okay, what's going on? How are you? And then you're going to connect. If they're saying, I want to go home, I want to go home, you say, okay, so you want to go home. Home, you want to go home. So you're validating and they're going to hear, yes, yes, that's exactly it. I often, I want to go home too, right? You're helping empathize. You're saying, you're helping them understand, saying, I want to go home too. And then distract. So this is if you know about the person, you could say, well, tell me more about home. Where did you live? And then you slowly can start to branch off to different conversations, and they're not as focused on maybe wanting to go home. You can start talking about their neighborhood, where they lived, and then from where they lived, who were your neighbors. You could just find different ways to talk. And redirect with an activity, which we'll kind of talk about here. The last piece of the strategy is engage. So let's say someone is bored. So actually we'll say with stimulation. So yeah, they're bored. So you might want to provide some music. Do they have the hearing aids in? Do you need to use a pocket talker? So any sort of corrective device or sound amplifier to help them engage a bit more. If they're fidgeting, you could do a rummage box of all of their favorite items. So let's say someone likes to, someone with a hairdresser, you could put clips, rollers, things in a box just to help rummage and something for them to do if they're seeking stimulation. Folding is huge. Just get the person to fold your laundry, fold clothes, bring baby clothes in, anything that they could be folding and doing it feeling purposeful. So let's say someone's super, super high, anxious. We want to help relax. You can put more relaxing music, maybe jazz, calming music, white sound, or noise canceling headphones if they can tolerate anything on their ears, or just a nice warm blanket. You could buy warmers for your blankets. I think on Amazon we have one here that sometimes it just helps calm someone. Physically active, walking, doing arm exercises, and that's where you might have a physiotherapist come in from the community to help with any of those exercises. Okay, so I tried, I'm at 32 minutes, so I know that's a lot of information, but I want to make sure we have time to have a discussion, to ask if there's any questions you need clarification on though, or